Thank you, Gio. Thank you, Anjum. And thank you so much, Raquel. Um, so pretend you're looking at me in a white coat and in a nice, clean office, and we'll do a little visit here. Now, ground rules for both our patient participants. Obviously, Raquel, we don't want you anywhere out of your comfort zone. We wish this to be illustrative. And so if I ask anything that you prefer not to answer, you can approach it one of several ways. You can say, next question, please. You can make up something, or whatever you like if we're asking something that for some reason you prefer not to answer. Because this is for educational purposes. We certainly don't plan on arriving at nor really discussing any forms of treatment other than possibly some basic common sense things, depending on where we're at, or very broad consensus items. Certainly no specific pharmacologic treatments. And anyone who tells you that they know a lot about persisting or long COVID based on their years of experience, well, unfortunately, no one has years of experience knowing exactly what this particular problem does for people. So our intent is not to offer any specific medical advice. Our intent is to understand a little bit about persistent COVID symptoms and get past, I think, the idea that you get sick with COVID, you're sick for a few weeks, and then you're suddenly completely back to normal, because I think we're all coming to an understanding that that's not the case. Questions about that, Raquel, Gio, Anjum, or anyone?
Excuse me, about the COVID itself. You meant. I have a question because it has been discussed. It is possible that the virus goes through this blood-brain barrier?
Yes, we can definitely talk about that. And then I'll only add one other slight fine print legal disclaimer that any opinions I offer are my own and not representative of any organization and coronavirus or any of the other affiliated entities with it. So if it's okay, we'll start. Now I'll ask you the same kind of questions as if I were meeting you in an office. Okay? So do you have any allergies, or any substantial allergies?
No.
Okay. And your past medical history, have you had before you were ill with COVID, have you had problems with your heart, problems with your lungs, any other substantial medical history we should hear about?
No, not heart and not lungs. But at the 2007, I got really sick. I almost died.
And what was that from?
Because they didn't find what was happening to me, and at the end, when they found out, I was really bad, and I was missing 5 hormones severely. It was really bad.
Did they come to a diagnosis? Did they figure out what was wrong?
Yeah, at the end, it was all coming from the thyroid gland. The thyroid.
Diet, food, comida?
No. This here.
Thyroid?
Thyroid, yes. Thank you, Margot. Yes.
Oh, sorry.
Thyroid
Yeah.
gland. Thyroid.
Yes, thyroid. Thyroid.
So you were hypothyroid?
I was hypo, but it was for too much time, and then I got Hashimoto.
Thyroiditis, an inflammation of the thyroid.
Mm-hmm.
So Hashimoto's thyroiditis. Okay. And any other substantial illnesses in the past for you? Any major surgeries?
No.
Any unusual any unusual family history?
For my father's family, they got problems with the pancreas. They got this inflammation in the pancreas, or sugar problems. Till now, I didn't have any problem with it. By my mother's side, it was this thyroid problem. But I didn't know it. It was later on that I knew it.
I'm sorry, we know less about your mother's history, or your mother's side? Do I understand that correctly?
This thyroid problem.
Oh, thyroid problem comes from your
Sorry,
mother.
because I don't know how to pronounce it correctly. I'm sorry.
Doing fantastic. The
Yeah.
and you yourself, you don't have, as far as we know, any diabetes, no high blood pressure, nothing like that.
No.
Great. Okay. So now we'll go to what we call the history of present illness. Um, what symptoms started you to think that you might have COVID?
I had a lot of cough, but a lot. I couldn't stop it. And low fever, shocking. And then what it was really weird was an incredible dizziness, and nausea. It was really weird, but really, I never felt this in my life. And other symptoms that I wrote here just to you to know.
So a cough, low fever, dizziness, and nausea,
And diarrhea.
and diarrhea. And did those all start at the same time?
Yes, this started at the same time
How
for
long ago?
10 days.
10 days from today, or they lasted 10 days?
The last 10 days, I felt bad the March 10th.
March 10th?
March 10th.
Okay. And did it come on suddenly? You were fine March 9th
Yes, yes,
and
yes.
March 10th. So it hit you, we'd say in English, like a brick wall or like a truck.
Uh,
It,
uh,
it
well,
came on all very
maybe
suddenly.
maybe I started first with cough and fever for one day, but
Mhm.
it was one day, not more, and then it was all the rest. Shocking also. I had pain and swelling in my eyes. They got inflamed, and really hard and severe headaches all the days. Yeah,
The and then with the cough, did you bring anything up, or was it a dry cough or a wet cough?
dry cough.
Dry cough. Okay.
Nothing was out.
Much in the way of aches and pains, or not really?
Yeah, I had pain, general pain, but also in my feet. I was feeling my feet, my like I don't know, really warm and really hot, and I don't know. It was weird.
Any pins and needles in your fingers or in the feet, or feeling
No,
like they fell asleep? None of that. Okay. But hot and cold, or just hot, warmth, uncomfortable heat in the feet.
yeah, it was uncomfortable here. It was like yes, I
Okay.
don't know.
So so March 10th, did you go to a doctor or a hospital, or did you call a testing center?
It was all saturated. The line was saturated. We couldn't we because that was it, that I was one day or two at home, like, oh, is this or is not this, but then I felt really all the rest, and then it was everything in alarm. I mean, the country was on alarm, and we couldn't get out of the houses, so we couldn't go to the doctor.
So were you eventually able to get tested, or did you just self-isolate, or what did you do during that period?
If they said if you are not over 38 of fever, I don't know, because we measure this in Celsius, you shouldn't go to the hospital.
Hmm.
So
So they didn't
so
want to give you a test.
no, Spain is totally broke, so they didn't have tests by then. They were keeping the test for the really sick people. What was the it was all the people what was over 38 or really sick.
And so Geo has put in the chat, for those of us that speak Fahrenheit, 100.4. And so you were running a low-grade temperature, and and if you don't mind me asking, how old are you?
40 years old.
40 years old. Okay. And would that have changed if you were, say, over 65, or do you know?
Excuse me?
Would it have mattered if you were older, if depending on your age, would they have had you come in, or anybody without a high temperature, they weren't going to test?
Correct.
Okay. And so you stayed at home then for the 10 days while you were very sick?
Yeah, and more because it was we couldn't get out of the houses.
And were you eventually able to get a test?
3 months later.
Wow.
Yeah.
Okay.
Because meal symptoms we were all treated like this, like because Spain is broke, it's totally broke.
Okay. Um, so so you felt awful for 10 days. You were eventually able to get a test 3 months after your symptoms started. Do you know if it was a molecular, a PCR test, or if it was an antigen-based test?
I think it was a PCR,
PCR. And what did it show?
negative.
Negative. Okay. And is that, as far as directly testing for COVID, that's what you've had so far is one test?
Excuse me?
Yeah, that was your only test so far
Yeah,
for COVID. Eh,
yes.
Now, I believe you've also had some other diagnostic tests. Is that correct?
No, now they are gonna make me an antibody test. I'm
Okay.
waiting.
Okay, and you haven't had that. You did have some sort of brain imaging, some other things? You've had some other medical tests.
Yes, yes, yes. Yesterday, because yeah, these symptoms were increasing, and some of them were decreasing, and others appeared.
Mm-hmm.
So at the end, I had the right side of my body inflamed.
Mm-hmm.
It started by my middle finger at the right hand
Mm-hmm.
and went through the hand, my arm. Now I have 3 fingers and my arm, and goes down till my knee and my feet. It's all the half part. And yesterday I couldn't stand up from my bed. That I was really bad. I called the doctor and she said that I should go to the hospital because I was waiting for the specialist. And I went to the hospital and they made me a brain image and blood test. The brain image showed that I have, I wrote it here. I'm not sure if I'm gonna say it well. Uh, brain, oh, yes. Mild asymmetry in the size of the lateral ventricles. And the blood test, and they sent me to the neurologist. I'm waiting, and I'm waiting for some results because the blood test is incomplete. They needed more time for other results, but the first results were low red blood cell distribution with low lymphocyte on blood. I was in 16,700, and meals low sodium. All the rest was okay.
How
But
low was the sodium, if I could ask? Did it give a number for the sodium?
uh,
Somewhere in the 120s to 140s. Only if it's easy. We've got plenty of folks here listening. If it, we can move on to other things.
111.
Your sodium's 111.
Mm-hmm.
So they noted that as low. That's fairly low.
Mm-hmm.
Huh. Okay. And no one has spoken to you about that result at this point.
No, I'm waiting for the neurologist, they said.
Okay. Interesting. All right. Um, so you were very ill for 10 days. And then did you get to a point where you were fine, or what happened in between the 10 days when you had the cough, the fever, the dizziness, the nausea and diarrhea, and now? Which symptom did the symptoms? Some of the symptoms stay the whole period, or they went away and then came back?
Um, yes, they went out and they came back. It was like how it's called, like a wave, let's say. I- and the cough was out and I thought it was okay, and then it came back, and also the low fever. But what I had all these days was this pain in the eyes when I woke up and I do this. So this was like inflamed, and tiredness. I also had red spots here on my chest, and it went through my arms, and it was with relief. It wasn't, they weren't really flat. And this was for yeah, 7 days, and they went out.
And you've never had any problems like this before, other than your thyroid problem. You've been a young, healthy person.
Yes, yes, yes.
And were you working before all this, before COVID and before the lockdowns, or? Uh,
Yes.
and have you been able to work since getting sick, or no?
Yes, but yeah, but they fired me because they are on crisis.
Oh, okay, so it's a combination of economic, and then you've been sick too.
Hmm.
Okay, all right. Anything else we should hear about the symptoms, or where things are at, or your test results?
Well, just 2 weeks ago, I was diagnosed with pneumonia, but
Will
this
you?
was 2 weeks ago. I don't really understand. I don't know if I didn't get uh, I don't know. Or it was a reinfection, or the virus was there working. I'm not sure.
And how did that show up? What caused you to seek care for that?
Could you repeat, please?
Um, had something changed after March that caused you to go see a doctor again, or
Yeah, yeah, because I had cough all this month. I had cough. It went and come, and then it was all the days. And I said to my doctor, "Look, I have cough," and she said, "Okay, let's do an image of your lungs because it's not normal." So they saw I had pneumonia.
have you had a chest CT, or was that an X-ray only?
RX,
X-ray.
X-rays. Yes, correct.
Okay. And did they ever culture a sputum? Were you bringing up anything with this?
Since I take this aerosol sprays, yes, I had some snot out. I have some. And now it's every day that I have I cough, and I have this, but not
Yeah.
before.
Okay. Are you getting better from that standpoint?
I have a revision in 1 week.
Okay. Were, so you were on some medication for the thyroid ever since 2007?
Oh, yes, yes. I got worse and worse on time of this thyroid. And one thing I forgot to tell you is after 2 weeks later of this March 10th, I went to the hospital because my doctor told me to make a blood test because I was really tired again, and they had to increase my hormones intake. So
Okay.
I don't know if it got inflamed as well or what happened. But
Now, well, certainly stress or anything else, or what we call coexisting illness, can affect thyroid levels. Or obviously, if it is COVID, then COVID could cause inflammation in the thyroid too. We don't know how much thyroid function was left after the Hashimoto's. Um, were you on any other significant medications before getting sick in March?
before I was taking the thyroid hormones, and I take 20 milligrams of Prozac.
Okay.
because I feel a bit sad till I was this ill, and I'm tired, and I'm not the same. I'm not good.
Is the
So
Prozac new since March, or were you on Prozac, say, in 2019 also?
no, I wasn't. It was recently that my doctor gave me this at the latest 2019.
Okay. All right. Um, so other symptoms, other things in the from March till now that we should hear about?
Um, Symptoms, no. Well, this problem with my feet, that they got hit,
Mm-hmm.
it came till my knee. It was really weird. It was this part of my body was hit, warm, and I don't know. I felt really weird on my legs, but till my knee, I don't know.
Okay. All right. If I'm understanding the lab results, so where we're at is 10 days of multi-system illness, which included fever, cough, dizziness, nausea, diarrhea, and facial, we call it facial edema, facial swelling even periorbital around your eyelids,
Mm-hmm.
and then some pain in the feet, and then you had a rash on the front of your chest that now has gone away. That subsided, and but you still have some dizziness and tiredness and shortness of breath and a cough.
Cough, yes, and tiredness, yes, but nothing, not the rest that you mentioned.
Okay, all right. And are you still having any fevers, or has that settled down?
No, this went away since I am on antibiotic, because after this pneumonia, they gave me antibiotics, these aerosol sprays, and since I went yesterday to the hospital, they gave me this pregabalin,
Pregabalin. Yeah. Yep.
and I feel much better of the pain. Really, I feel released, and they gave me also this. Strong enantium is, and I wrote it around here. It's I don't know. It's dexkef dexkef. I'm gonna write it. Excuse me, because it's a bit weird. All this together in a pills. I don't know. It's called. I know.
It looks like it's some tramadol is a pain medication, and the other ones that may be a Spain. I'm not recognizing that particular one. That may be one a Spanish medication. Um, but what is interesting is your serum sodium level is fairly low, and so that would be what we call hyponatremia by itself. It's tough to know the significance. And then Dr. Chowdhury is asking whether you're on dexamethasone, but dexamethasone, which is sometimes used for COVID treatment. Uh, Geo is typing dextroketoprofen. That I think is probably a variation of ibuprofen. In America, that would be called Motrin or one of those. I think that's going to be uh, basically a pain medication. Does that sound like it's your dexketoprofen without looking it up? I'm guessing that's some sort of pain medication. I could be wrong on that. An anti-inflammatory and pain medication.
I feel much better of my pain.
Mhm.
I feel much better.
Okay. Um, so again, I'm guessing if that's a variation of tramadol, what we call tramadol in the U.S., which is, I think, well, that would be a pain medication. So you are having some improvement now. Um, all right. So any other things about and now if we were to examine you, are there any physical findings? Is there any abnormalities, do you know, that we'd spot? Or your rash is gone? Uh,
Yes. Well, my skin is weird. I don't, I can't explain it, but my skin is weird. I don't feel my skin like before, but it's a feeling, I don't know.
Well, we were hoping to have a second. We were hoping Blanca would join us also. And as I recall, I think you might have. I think you were there for some of the discussion. The people that did hear that, Blanca also had had a negative test, and her main symptom was dull pain in her chest. And then also she had some exercise intolerance. If she went up a flight of stairs, she would have, I think, be short of breath and feel weak. Now, are you back to your normal energy level or not really?
Not really, no.
Okay. So I'll just outline very quickly, and others in the audience may have plenty of comments about what they know about persisting or long COVID. And you also may have some comments and or questions. And other than what I'll just outline very quickly here, then my intent would be to be more facilitate discussion rather than lead it at that point. So coronavirus, we know, hits the angiotensin converting enzyme receptor, which is involved in blood pressure regulation and regulating things, between blood pressure and lungs and kidney. And good for the virus and bad for us, that ACE2 receptor is kind of all over the place in a lot of cells. And the other problem that the COVID seems to be able to do is it causes an inflammatory response, and it also may directly interfere with the clotting cascade, how blood clots, and whether it clots too easily or not easily enough, depending on a particular patient. And since it can affect circulation and affect the immune system, and those things affect many organ systems, we think that may be why there are many organ systems that COVID can cause problems for. So specifically, we know in the GI tract or the gut, so diarrhea, maybe a third of the cases that present, and then possibly some abdominal pain in the persisting COVID cases. Luckily, I think, Raquel, in your situation, you're not having trouble eating. You're not currently having trouble with taste or smell, and you really didn't have trouble with that before. Is that correct?
It's correct. Well, at the first days I couldn't eat, but later on I could eat normally, and I was hungry. But at the beginning, not really.
Okay.
The first day is not really.
And the diarrhea, you're not having abdominal pain, and the diarrhea has really settled down.
Excuse me, could you repeat the question?
The diarrhea, that's settled down. You're not having problems now with that.
No, 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 nowadays, no.
Okay. And we have I want to be sure we'll get back to it. Joaquin asks, is oxygen saturation still affected? Did they ever put a pulse oximeter, a device, and measure your blood saturation because of the pneumonia or anything? Pulse oximetry?
This thing that measures the yes, I was normal.
Okay. Well, it has a little red light to it usually.
Yes,
Yeah.
I was normal.
Okay. So, and to Joaquin's question, the best, as far as I know, is in some patients, they have persisting oxygen deficits, sometimes symptomatic. There was a short series of a few patients where it showed 30% lung impairment persisting after COVID, but the problem is it was a very small series, and I have not been able to look to see if that's been repeated over any large studies. It sounds like in your case, as far as we know, your lung function was normal at the start, and there are changes on X-ray, but otherwise you're able to go up a flight of stairs and you're not huffing and puffing. You're not problems with respiration at the top of the stairs, are you, or are you?
If I change my posture or my body posture, or when I go to sleep or when I wake up, I don't really walk a lot, so I don't really go and walk.
Mm-hmm.
But yes, I'm tired, and I need to breathe more, and then I cough. Or
Okay.
if I change my body position, I cough. This
So
thing.
we, yeah. So we do certainly still have some loss of energy, and really we have what we would call exertional dyspnea. You do have a diminished exercise tolerance.
Excuse me if I have?
You do have some reduced tolerance for exertion, for activity.
Yes, yes,
Yeah.
yes. And I don't go, I don't walk a lot, really. I don't really go out of from home. But if I walk a bit, yes, yes.
Okay, thanks. So we talked about the GI tract, the diarrhea, the abdominal pain. Luckily, you're not having much of that now. And we actually talked about the loss of sense of smell and loss of taste, but yours was more a loss of appetite early and not so much the sense of smell or taste, which in most patients, it seems to eventually come back, the ones that do lose it, but apparently not all patients. We're not sure if that can be a permanent problem for some. Kidney, it can definitely affect kidney. We don't know that that's happened in your case, although your low sodium is interesting. That could be for any number of reasons. I would imagine that in the next few days, hopefully someone will get back to you on that test and possibly repeat it. Um, and the effects on the kidneys we think has to do with the ACE receptors in the kidneys, but there may be several ways that COVID affects kidneys. And certainly during the acute illness, not the chronic illness, it can have a very substantial impact on the kidneys. Smell we talked about, lungs obviously, and we do think there's a chance of some permanent effects. Pancreas, it was interesting because your family has pancreas problems. But to our knowledge for you, we've not had anything specific in that area. But there are ACE receptors and there's reports of pancreatitis from COVID, including some question of whether pancreatic function is affected for some of the people who have persisting COVID. Heart is a very serious issue. We've, on some of the late night calls, we've talked about it before. And I think you might have been on the call with Blanca where we were discussing that possibility for her, whether she had had some inflammation even that might have affected the heart. And that could be one reason why some patients will have reduced exercise tolerance. Um, it takes a fair amount of testing to prove that conclusively in any one patient. And generally that testing right now will be saved for the people who are older and who have pre-existing heart conditions, because they're the ones we're going to be thinking about those effects more commonly in. Some question of effects on gallbladder. Obviously, the people have talked about the spots on the toes, and certainly chronic pain and the whole range of neurologic effects, which range from inflammation in the brain to Guillain-Barré syndrome, and some chronic muscle aches and pains, which really seem to have applied more to Blanca's case than yours. On the report where they said one-sided, I think ventricular changes in your, they did brain imaging. It was a head CT that they did. You had a test, yeah.
See, yes. It was an image, but it was I don't know, in here is called this, I don't know, in USA.
Okay. And did they give an overall impression from that test, or was that what you had read to us, the impression?
No, is what I have no idea, is what they wrote here, that I had low asymmetry. I don't know.
That sounds what we call a fairly mild finding, and we're guessing that that's a tomographia, basically a CAT scan.
Excuse me?
Um, Jonathan offers that it may be, I hope I'm pronouncing it right, tomographia, a sliced image CAT scan.
Yeah,
Grafía
which
computada
is like this.
o resonancia magnética, podría ser.
No. Voy a buscarlo. I'm gonna look.
Oximetrio de pulso would be the pulse oximetry. That's the device on the finger. But the tomografia computada would be the CAT scan.
Yeah, I think it's this tomografía axial computizada.
That's a CAT scan. Yeah. So did they give a summary or impression, or all they said was the asymmetry?
They said everything it was okay, but this.
Yeah, I don't think that sounds, For one, they certainly didn't mention any inflammation. I think that's going to be what we call artifact. Here's a very good question from Derek Van Gennep. And he's asking, do you have any memory deficits, any difficulty with memory, changes in your thinking, confusion?
Yes.
And what, can you be more specific or tell us some things about that?
I'm not the same like before. It's just that this is what I know because I forgot things. I'm confused. I'm confused and I don't know. I'm not fast like before, let's say.
Can you tell us what kind of work you were doing?
Marketing.
Marketing. So that's a fast business.
Yeah, I know. Yes.
Yeah. Is that getting better? Can you tell, or you're not sure?
Mm.
No.
It's weird because this dizziness that I had at the beginning, these first days, it never came back, but it was really weird. It was like, I don't know, like if I had a shake in my brain, like zzz, I don't know. It was like a short circuit. I don't know. I can't explain. I never felt this before. It was a really weird dizziness. I can't explain really.
Any vision changes? Your vision's fine?
No, no, no.
Okay. It's questions for me or things that before we open it up to the group, things that you feel we should cover or discuss, or as I said, any questions? How can we as a group be helpful to you?
No, I just wanted to know this if the virus could finally go through this brain barrier, blood-brain barrier.
Absolutely. There's many reports of symptoms very similar to what you described, and we don't know the full mechanisms. It could be as simple as microemboli causing problems, in effect, sort of the equivalent of tiny microscopic mini strokes because of the effect on clotting, in which case the virus wouldn't even need to travel past the blood-brain barrier. For people who don't know what that is, we conceptually think of a strong barrier between substances in the circulation and the protected areas of the brain uh, that 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 those substances don't travel across. But the reality is, as we know, because there's many what we call psychoactive substances, there's many things we can take, and they manage to find their way into the brain and affect its function. Um, it looks right now like COVID is one of those things that can definitely cause inflammation in the brain. It can cause strokes, um, and it can cause other neurologic effects, both what we call central, up in the head, or peripheral, out in the body, the arms, the legs, the muscular system, but through the nervous system, or even the autonomic nervous system that regulates things like heart rate and blood pressure. Uh, we think we're seeing effects on all those things from COVID, including encephalopathy, our ability to think, encephalitis would be inflammation of the brain. Uh, there's plenty of reports of all those things. And then Guillain-Barré syndrome in the long-term COVID. Um, could I fit your symptoms into any one of those categories? Not really. I mean, it has pieces of several of those. But would I say, aha, oh, here's what's going on? I couldn't. Maybe someone else can, but I'm not hearing it. Not with the test you've had so far. The low sodium is interesting, and I imagine that they'll be looking at that a little further. Normal sodium, if I'm thinking of the right test, should be up around 140 or so. And 111, yours was 111, I believe, right?
Excuse me.
Your sodium level, your blood salt level was in the 111 range. Did I recall that correctly? That's fairly low. I don't know the normal testing range for your hospital or for where it was done. Or if it may be some different test than what I'm thinking of.
135 between 135 and 150.
Sounds like I'm talking about the right kind of test. 111 would be pretty low. 111 would have my attention. In fact, that might be worth once the sun rises and we end the call. No, once the clinic's open, just call them and say, hey, you were wondering, because let them know that you noticed that that was outside that normal range, and see what they have to tell you there. And you've never had any seizure disorder, epilepsy or anything like that, right?
No, 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 no.
Okay. All right. And have they checked the thyroid level lately? Do you know if your thyroid's okay now? They adjusted your medication, right?
Yeah, it was at the, let's say, at the beginning of April, latest March, when I did this, and they said they are gonna check me again at the beginning of September.
Okay. All right. Which sounds very reasonable. Thyroid doesn't change rapidly. It's not a sports car. It's more like a sort of slow, sluggish.
Yeah, I'm taking 150 milligrams. And I forgot to tell that I still have hard headaches. This last was but not that. It's not daily. Let's say it's just sometimes. But I can't even speak. You know, it's really hard.
I think they're going to need to investigate that sodium. That sodium alone would cause some headaches and thinking changes, and then they need to figure out why the sodium's so low, it seems to me. But it certainly could be long COVID, and it'll be very interesting to get the antibody test also, which may give some information here that might be, hopefully be able to fill us all in what happens. I'm going to mute, and Gio's coming back on, and then move more to a facilitative role. Thanks.
Thank you so much, Gary, for running the medical questions, and Raquel for answering. Thank you. So one of the things that I'm wondering, Raquel, is how has COVID changed your life? Like, I have a audio echo problem. Is that for everybody?
Yeah, it's
Okay.
pretty bad. Can you try reconnecting?
Yeah, I'm gonna fix the audio. Sorry, everyone. 1 second.
While he's getting the audio set back up, Tracy has sent us some questions. The first one is for Gary. Gary, are there known measures that those inflicted can take to assist with recovery, like sleep, vitamins, breathing exercises, or any others?
At the risk of sounding like a hypocrite, if anyone occasionally has seen me on the late night Zoom here or in the Slack channels, I'm a big believer in sleep hygiene. I don't know of any illnesses that are made better by not getting adequate sleep. So I think we're pretty safe in saying, one, let me just express my appreciation, and I'll go ahead and express appreciation for the group, for you taking time out of your sleep this early morning to be with us. Those that don't realize the European time zone, Raquel has gone out of her way to help us out here. But obviously, in general, where you can, a minimum preferably of 8 hours of sleep, and on a fairly steady basis, and broadly the overall topic of sleep hygiene. Vitamin D is an open question. I think in general, if people want to use vitamin D in the 1,000 to 2,000 unit, IU is an abbreviation for international unit. It's probably safe for most people unless there's pre-existing kidney illness. Has it been shown to help definitively in any health conditions? Not necessarily, and I would discuss it with your personal doctor. It's relatively inexpensive and at low doses unlikely to cause harm, and it may be helpful. I think that's still an open question with or without COVID. breathing exercises. Breathing exercises definitely have a role in all kinds of ways of relaxation. And so even as that relates to sleep hygiene or reduction overall of anxiety, I'm sure there are some good breathing exercises, whether they're in a yoga discipline or something that's under medical guidance, or for people recovering after hospitalization, they'll give a plastic breathing toy called an incentive spirometer to help expand the lungs. But all those things are good. They help recruit the lower portions of the lung, and certainly are not going to hurt. I think that covered the range of Tracy's questions. We'll see if, I'll mute again. We'll see how Gio's audio, and then I see Derek has some questions too.
Raquel also, there was a follow-up from that, from Tracy, where she was wondering if you are doing any of those different lifestyle changes that Gary just discussed, and if you've seen any change from those.
Yeah, I forgot to say that I am vitamin D deficit. I was at 3, and every month I have to take this hydroferol. I don't know if it's the same in USA. I take this every month. I forgot because it's one bottle every month. And yeah, I take this vitamin D, vitamin D, sorry. I have problems with my sleeping. I really do since this COVID. But yesterday I slept much better since I don't have this pain. And so I wish I can sleep better since now on. And I don't really know breathing exercises, but yes, I should check, because I think from now on I need to take better care of myself because all of this. And yes, I tried sometimes like how is called this in English? I'm not sure, when they put a lot of needles on you. I'm not sure.
Acupuncture.
Actually, oh, okay. But yes, it was a quite interesting experience. But I got afraid because I started to cry a lot. So I don't know. It was impressive. Maybe I should do it. I don't know. I'm gonna do something for sure.
Acupuncture. I'm trained as a massage therapist, so it's very close to my field, and it is some strange wizardry. I've seen it work miracles. So acupuncture is one of the things that a lot of people who don't have any other options go to, and it can definitely improve things. The mechanisms of it, though, are rather difficult to untangle. I guess we have a question here. Are there two distinct phases of COVID? One where the virus is present and doing damage, and another dealing with the damage afterward. Gary, you're muted.
Yeah, fix that. Thanks, sorry. I'll have to be careful without, just quickly doing a literature search to see if anybody's updated this. But I think it's fairly safe to say that generally we conceptualize it as the virus hits, it's quiet for a day or two, what we call incubation or generation time, as it's probably slowly replicating, but it hasn't sort of taken off. That inside a body, we know about the J curve or the hockey stick in a population, but that probably is a similar process to what happens in the body. You get infected, and there's initially a very low level of replication, and then there's sort of a chain reaction as the first couple virus particles or the first couple cells that have exploded and released all their virus. Now you get this chain reaction, and suddenly you get an exponential increase in the viral load that's circulating through an individual. And it's very analogous to what was happening in January and February in different countries, where first there'd be one case and then suddenly it just went up exponentially. So, and then we think that the virus sort of burns itself out. The immune system upregulates, something takes control of it. One way or another, the virus is no longer in an individual replicating as rapidly. And also that would match with the idea that the virus is, that the person isn't as infectious. There's a lot of literature suggesting that we're most infectious a day or two actually before we start symptoms. Now that may be because once we get symptoms, we tend to get pulled out of the population. But I think when they do repeated testing, they're finding that the viral loads are not as high once the person starts typically to show symptoms. So, all right, to bring this back to a short close on that, there's a period of time that we would call the acute illness. And that's the viral replicates, the person gets sick, they show their classic symptoms, and then that sort of resolves. And they're discharged from the hospital and their antibody profiles change. And now we're into the prolonged COVID. And the prolonged COVID, which we don't really understand, and it varies, persistent COVID, long COVID, that may be any number of things. One, it may be the after effects of the immune damage, and this may vary from patient to patient because there is not a completely typical case of long COVID. We don't know for sure, since both Raquel and Blanca's not here to tell us her details, but both of them actually had negative COVID tests. So we can't even know for sure that what they're suffering is COVID followed by long COVID, although we think most likely both of their cases would match pretty well. But their symptoms are each different. Blanca's symptoms were more chest pain, and Raquel's symptoms have been focused more on pneumonia-like symptoms, possibly hyponatremia, low sodium, and feeling not right, and headaches. And so those are some differences. So could it be that the virus is still replicating in one long COVID patient, and in another patient, they're suffering damage either from damage to the blood vessel linings or changes in the blood clotting system, or some impact of the immune system attacking some nerves? It could be all those things, unfortunately, in different people. I'm muting.
So to the question about vitamin D, calcifediol or hydrariol, which is I think the Spanish pronunciation, is a processed form of vitamin D. So it's vitamin D3 that's been sort of processed as the liver would process it. So it's probably more bioavailable, but less stable.
We could do 3 of these sessions on vitamin D alone, and which is what the conflicting evidence as to which one helps. The best vitamin D to take is one that your doctor doesn't do this or like this when they hear about it. Or if it's something that your doctor is good with you taking and you've discussed it with them and you trust them, and it's in the dose they recommend, then it's probably okay. And if it makes you feel better, it's probably okay. Is there proof it's going to help? We don't have that proof right now. Is there some things suggesting that vitamin D may help in several circumstances? It's possible. And I don't think we know yet which particular brand and which particular form. There's D3. I think there's a couple different forms of vitamin D. The one that there is some good evidence for, but I don't know how much this would fit in your situation right now, what we call green exercise. Under normal circumstances, getting outside on a bike or a jogging trail in the sunshine, as long as you use sunscreen if there's too much sun. But the vitamin D that we get by eating a good, healthy overall diet and getting out with some sunshine rays. Right now, those sunshine rays, you want to be only around people that are wearing masks and are at least 6 feet apart. And so if there's nice isolated beaches or jogging trails, get some vitamin D that way. That's my comments on vitamin D.
Thanks, Gary. Raquel, do you have any idea how you got infected?
I think I have an idea because my partner, he's Austrian, and he came here the latest February at the 27th, I think, with a friend because he had to take some things and the friend helped him. Excuse me. And the friend was coughing, was cold, and I don't know, or maybe were them that came to the airport and they got sick, or they got with the virus, because my boyfriend was sick and coughing like me, and it was coughing. They got also this wave. He stopped coughing and start coughing and stop coughing, but he was much better than me. But I'm pretty sure it was them because it was before everything exploded, and they didn't take care by the airports, or was this friend that it was cold. It was coughing and all the time. I don't know. I think it was something like this.
Did he get tested?
In Austria, they didn't get the test either if they didn't were bad, and he was really mild, more than I. So he just got cough and some fever at the beginning, but he didn't even have diarrhea and all this. He was really mild, but he had cough for almost 2 months or 3, going and coming and going and coming and going. It was weird because he really doesn't cough normally.
So how long is that cough cycle? Like a few days of coughing and then a few not, or is it like a week or 2 weeks? Does it change?
It changed at the beginning is more, and it's like a wave that goes decreasing, let's say.
Okay.
You would write it would be like this, something like this.
Okay.
I see a question about the immune system and also a brief comment on D. I'm happy to try and address both of those. Yeah.
Go ahead.
Okay. So the immune system, there's a question from Lindsay. We do know that stress is immunosuppressant, and that's clearly established in many studies. I first took as a undergrad pre-med many years ago, took a course from one of the researchers that had shown that you can actually provoke asthma attacks using plastic flowers. He had designed a clever experiment demonstrating that the immune system can be triggered by our thinking. Asthma is an immune-mediated disease, and so people that were conditioned to have attacks from certain species of flowers, it turned out that you could duplicate that with visual stimuli and create the same attack. And there's been many other studies that show all the stress mediators, cortisol, things like that. You can measure, and you can measure their impacts on the immune system. So the short answer on that is yes, stress, fear, anxiety definitely probably create some vicious cycles which make it more difficult to recover. And then people with persisting or long COVID right now would fall into a category similar to chronic pain or even some PTSD or anxiety things of what we call invisible illnesses, which are illnesses in general that we're not really good at dealing with in conventional medicine, unfortunately. And do we think those make it worse? Yes, I would be almost certain they do. Okay, there's a question and an answer about full aches. Derek asks if there's full aches, and Raquel answers she did have that, and she continues to have that. And then Tracy also asks about 4,000 units is a little high in my opinion for vitamin D. If you're doing it in conjunction with a doctor that you trust, for your particular physician, for your particular health conditions, it's probably okay. I would not recommend it as a general dose. on average. Otherwise healthy people, if you're going to take D, I would take it in the 1,000 to 2,000. But again, all of it becomes a matter of faith, and I would definitely discuss it with an individual doc that knows your personal history. So that's on. I didn't want to ignore that one. I'm muting. Thanks.
All right. One second here. So, what does the literature have to say about long COVID symptoms? What do we have a more fleshed out understanding of? Gary?
Okay. I mean, it depends on which literature. There's a number of physicians around the world who all now have suffered long COVID, and they're very active on social media advocating for registries. I think it's the British Lung Disease Association I actually forwarded it in my Twitter account to give it wider spread. They're trying to recruit patients to enroll in registries. It's way too early for us to speak definitively in any way on literature about long COVID in an illness that's only been present in the human population, as far as we know, since about last November. So I'm looking here, I pulled out one good, this is actually written by a lay journalist, not just the lungs, COVID-19 acts like no other respiratory virus, but it was a nice summary. This is from late June. And I think this has gotten some circulation, something called Stat News, but it's well written and it's well referenced, talking about the different organ systems that this can hit. No one has really published a study of 1,000 patients with long COVID. I can say that with reasonable certainty because I did that literature search updated today. And as Tracy B points out, that is something that some automated tools can help with. Packages like, or systems like the one that Nipur introduced us to today in the big call. But basically what you really need is long-term registries tracking patients and tracking their course, and then good statistical analysis to really develop some trends, and then have the science catch up with it where we can really explain those trends. And the short answer is I don't think we're there yet. You know, I'm happy to share some references. There were references. We have that, it's now com-long-covid. That had a collection of references that we started early. And I think a couple of us have dropped some links. Dr. Bernard put some good stuff about neurologic in there. We're somewhat keeping that up, but again, those registries, they're just getting formed. So you're going to find more in social media and Twitter than you will in literature search at this point. Thanks.
So we don't have a lot of good data on health on long COVID and population or individual people. We have some knowledge, but a lot of it's running off of anecdote. One of the figures that I have seen is roughly 10% of people infected have long COVID symptoms, but that's not strongly certain. It may be higher than that, or maybe somewhat lower than that. And so it's not a trivially small portion of the population, which is a very important point, because a lot of people think that it's only old people who get really sick, and that basically it's you get sick and you die, or you get sick and you get better. And for many people, that is not the case.
Derek asks an interesting point, and in general, you know, I'm in favor of green exercise, and I'm also in favor of sunshine as and transparency as a disinfectant. Derek asks, is there any way this could be what we call psychosomatic? Raquel, I'll ask you, is it okay if we discuss that possibility here? Okay, so psychosomatic gets into a different area of medicine that's still very important. There's somatoform or psychosomatic illness, and there's factitious disorders, and there's physiologic illness, and they're three different things. So my best guess is most likely this is post-COVID. We don't know that for sure. My best guess is you had COVID, you probably caught it from your partner. We don't know that for sure. You might have caught some other viral respiratory illness from him, and then may have gotten sick with something else, what we call a superinfection or an independent infection when you got that pneumonia. We don't know that, but most likely the world was suffering from a lot of COVID. The story sounds certainly plausible and matches many stories that could match COVID. And so we use something called Occam's razor, which is the most likely explanation is the most likely explanation. Factitious disorder is when someone chooses to fake having an illness. There's nothing in here that would cause me to suspect that. Most of the time in my experience with those cases, there's some obvious reason or motivation for the person to choose to pretend to have an illness. And this doesn't strike me as that. There are the somatoform disorders where the person is convinced that they have some illness, and it's actually more related to their emotional state and has nothing to do with physiologic in their body, with what's going on physiologically. My best guess is that's not the case here. For one, it would have trouble explaining that low sodium level. Those cases are complicated. They do happen. And that can be true for anything ranging from appendicitis to COVID. But, you know, in any one patient who shows up in an office with a certain set of complaints, but no reason particularly to think that that's the case here. Did that answer to everybody's satisfaction the issues of somatoform or somatization or psychosomatic illness? Okay, thanks.
To let the lovely Raquel get off and go to sleep, I would like to ask Raquel, is there anything you'd like to say? And then we'll let you get off to bed. Many thanks for coming and speaking with us and sharing some of your story.
Excuse me, you mean about this illness? If I would like to share something else?
Yeah.
Well, no, really. We talk about everything, and yeah. I'm actually. I just would like to say I'm pretty sure I had it because for really I had this really weird dizziness and I can explain. I never felt it, and this nausea that it was so weird. I knew it was something different because of this specifically, the nausea and the dizziness. It was I didn't felt it before, so I had dizziness before and nauseas, but nothing like this. And it was this 10 days, I don't know, with fever, and I had other colds, and they didn't were like this. They didn't be like this. Sorry, no. It's not science; it's an opinion, but I never felt like this before, and I never had a call like this before. Let's say. That's it.
All right. Thank you, Raquel. If you'd like to go off to bed, you have permission to do so. We really appreciate you staying up for us, giving us your time, and sharing your story with us. Much appreciation from everybody here. So thank you again. And good night.
Good night. Thank you, everybody. Bye-bye. Good night.
And we all hope that you get well and start to feel better. and the best of luck. And let's get more support for people with long COVID.
Thank you, Raquel. Thank you so much. And, you know, any questions you have anytime, you know where to find me. Yeah.
All right. I guess this may be a good time for us to open into a group discussion where we can all come on video and discuss long COVID. I think this is a good time for that. If anybody else has something that they would like to talk about in the area, otherwise we can make this the end of the call.
One thing that I wanted to ask Raquel was, is there anything that she feels that she could benefit with in terms of like what her government could do better? Or, you know, just her perspective of the, like where she's lacking in terms of, so maybe better info from the government, or it would be interesting getting her perspective on that.
Yeah, it would. That was a good question.
I can send her that question and she can get back to us, and I can put that in our channel on Slack.
I can probably
keep her for more than the hour.
Yeah, definitely. And then something like that we could drop as text into the video if I get it tomorrow for the edit. And we can definitely do more videos on the topics of COVID that we may have an opportunity to discuss such things. Derek, you had something?
Yeah, I have a question for Gary. Gary, what sort of probability would you put on the statement that she still has a virus in her body? Is it almost certainly that it's all gone and it's just after effects now?
Really, really tough question. Similar to the question of, do people get immune to COVID? You know, we know that, for example, chickenpox hangs out and gets reactivated years later as shingles. Herpes 1 and 2, the cold sores, not to be gross, but you know, you get a little stress and you get this big, you know, red thing on, you know. So that's a virus that's sitting there latent, and then under stress activates. I don't think we know, I've not seen any documentation yet that COVID reactivates. There was some debate as to what it meant when people seemed to have gotten COVID twice, but so far no one raised their hand worldwide and said, oh, that's clearly virus getting reactivated, even though theoretically it could have been. But you know, there haven't been many case reports of multiple episodes of COVID to begin with. Another weird one that I don't think we have a real physiologic understanding yet is post-polio syndrome. So when that didn't show up, when I was a medical student, we didn't know there was such a thing as post-polio syndrome. Now it's very real. I've seen many patients with it. I did a lot of population health with chronic illness and have seen much. And does that mean the virus is replicating in them, or that there's some delayed after effect of the damage that the virus does? I think in most of the cases, it's some sort of reactivation of the virus. But I think in some of the cases, it's downstream effects, even though the virus is already gone or isn't replicating.
Right. Margot, what are you wondering?
Yeah, I'm wondering about the implications of testing policy for people, for following people in a situation like Raquel. I mean, she wasn't able to get a test for a long time. And there are lots of people who have recovered and never gotten tests. And they may also be having long COVID, but the time has passed for when they could even get a test to prove that they had COVID. So I wonder what the implications of that are.
Well, over time, the way to address that, by the time we get there, it may not matter because maybe let's hope that there'll be a vaccine. But the way you'd address that, let's say there's no vaccine in the next 3 years, and let's say we have this horrible sort of dancing along. It's not even a dance. I call it a stagger or a stumble. We tried the hammer and we never got to the dance, and our hammer wasn't really that effective. So now we got this stagger stumble instead of the dance, which is, worldwide kind of what we're doing. So suppose you get registries, and suppose over 2 or 3 years you really have significant patient recruitment, and you begin really to see some statistically significant trends in those registries as to what is and isn't persistent COVID. Then what you would also do is you'd do some antibody testing on those people, and you'd look for differences in a cohort of asymptomatic people versus a cohort of people, say, with a certain symptom, and you'd compare their antibody profiles and look for significance. And that's how you would try and answer some of those questions.
But so in the longer term, there's a methodology for addressing them. But in the immediate term, I just wonder, are there going to be cases where people are living with these long-term effects, but somehow they're not counted either by a medical or a political system? It's as though it's invisible because there's no documentation. And if there are certain benefits available to people suffering long COVID, well, you can't get them if you can't prove it. So I'm just thinking these people like Raquel. Are there people who it's sort of a double whammy?
Are you asking, are there some gaps in the social safety net country by country?
Maybe that's what I'm asking.
And are you asking, were there some gaps even before COVID?
Well, I know there were.
Did I mute again?
I know there were.
And are you asking, is there some noise in our statistical data collection, even things like CDC pooling antigen and PCR tests? There's a fair amount of noise, and not all of it is by evil intent. Yes, I'm viewing long COVID as falling in the category of invisible illness. I think from an overall policymaking point of view, we're going to be much safer assuming it's real from a policy and humanitarian point of view. Humanitarian for the individual victim, and from a social point of view, not thinking herd immunity is a good idea. Recognizing that there's some very real risk in playing with the virus that we don't know much about because it's only been hitting us since November or so. And that in general, we haven't seen a whole lot of beneficial effects of viruses compared to the downside in terms of their unknowns. We have yet to discover many viruses that are mutating us into record-breaking Olympians or something. It seems like for the most part, when viruses have effects, they're mostly bad effects. They don't make us better.
Thanks, Gary.
We've got some really interesting things in the chat. So one of them is, any chance her symptoms trend with antibody concentration?
We don't know that yet. The antibody tests are not homogeneous, and I don't think there's been enough widespread diverse testing and strict comparison of symptom by symptom, especially in the long COVID population, partly because we're test limited worldwide for the most part anyways. And so the tests are hopefully getting safe where they might influence treatment. And a lot of that still has to be down the road kind of stuff, and in combination with those registries, because then you also got to tightly control for those symptoms to get that correlation.
Then another question from Tracy was, how much is known so far about the effects and damage from SARS-CoV-2, specifically versus immune response?
Yeah, Jeremy talks often about that cytokine storm and the, I forgot the other term in there. Well, we know that the bad, severe hospitalized patients, we have a rough idea, the lung injury and things like that. But I don't think we know all the subtle details yet and how they vary patient to patient. We do know there appears to be some cases of Guillain-Barré, which is a horrible neurologic illness that seems to be associated with some cases of COVID. That's probably an immune effect. But why one person, we know that that's not universal for COVID. Luckily, we haven't seen a huge pandemic of Guillain-Barré, but that would certainly be one immune-mediated one. Probably some of the kidney damage is almost certainly immune-mediated, but some of the kidney damage is also probably microemboli, would be my guess. I pulled up, in doing the quick update before this talk, there was a interesting one out of Germany, Annals of Internal Medicine. They just took their first, it was a hospital in Germany, and they did postmortems on their first 12 deaths from COVID. And they found unsuspected DVT, deep vein thrombosis, in 7 of them. And that's an astonishing rate. Now, maybe that hospital is just awful at preventing deep vein thrombosis in its intensive care patients. But given the other data about blood vessel effects and clotting effects, my guess is that's a real direct effect of COVID. And there's enough other evidence that we've got at least microemboli. There was a case series, it was still such low numbers that it's what you'd consider anecdotal, but there was a series of 5, all younger than the age of 50, in New England Journal, all with strokes, none of whom were able to talk. And that also speaks to the thromboembolic, the blood vessel, because apparently in megakaryocytes, which is one part of the platelet clotting system, megakaryocytes apparently have these ACE2 receptors. And then also there's links between the clotting cascade and the immune system also that are very complicated. You're talking about 2 very complicated dynamic systems. It falls right into good Nexi kind of stuff. I'm muting.
Well, Gary, you are the focus of the rest of our questions. So just wanted to give you a heads up. We're excited to learn more from you. Jonathan is wondering if it's possible for her to come into contact with the virus in some way and become reinfected periodically.
Yeah, and that's a good question that the straight, simple answer is we don't know. It seems most likely that there's not a lot of cases of recurring COVID or second exposure COVID. Maybe because once you've had it, you really get serious about staying away from folks who are coughing and aren't wearing masks. And also at this point, we are as a society in some locations a little more COVID aware and COVID prudent. It varies from place to place. There's not a lot of solid reports or long case studies of recurrent COVID. So short answer is we think that people don't really get the full immunity like we'd hope they would, but we also don't have a big series of repeat COVID.
Can one get long COVID after having been asymptomatic?
My best guess is yes. I think worldwide, I think we don't know.
Well, one way to rephrase that is that you don't have to be hospitalized or immediately panicking levels of sick in order to get long COVID. Like you can have a cough and, have a fever and that lasts for a couple days and maybe it's flu-like, and then a month later you still have a cough and you start to develop some odd symptoms like numbness or strange sensation, and maybe loss of smell or some sort of series of unfortunate knock-on symptoms that don't recover rapidly. This is not a foreign concept to infectious diseases. In February, I caught some kind of respiratory thing that could have been COVID, but it was a little bit early, and I didn't have any of the additional symptoms beyond a cough, which was productive the entire time, and usually COVID is non-productive, dry. But I still have some kind of productive cough, and it's been, 6 months? Long-term symptoms are not a strange, novel thing. The complexity and breadth of long-term symptoms that come with COVID, though, are a little bit more dramatic than is usual for long symptoms. But it's not a bizarre thing in and of itself medically.
Here's one that I think a lot of us have been wondering. Can you tell us more about the loss of sense of smell and taste that comes with COVID often?
All right, I'm going to say this is off the top of my head, and then promise at least Derek and anyone else, I'll make a note now to try and do a quick updated literature search, because I did come across some of that, but I didn't focus on trying to memorize it for this talk. So we call loss of smell anosmia, and in case anyone isn't aware, about 80% of our sense of taste is mediated by our smell. Anybody who loses their sense of smell, it's really sad, because they no longer can be gourmet wine tasters or enjoy fine restaurants. On the other hand, Big Macs are not nearly as disgusting as they normally are for the rest of us. So, all right.
Spicy.
Sorry. Okay.
That was a hot take. I like it though.
It's been a long day.
Yeah.
I think that, I believe there's some evidence the virus may be directly neurotropic. There's the cranial nerve that mediates smell comes right out in what's the cribriform plate. That's like one of your closest places where the brain is like connected with the outside world. That virus may get right to that and attack some of those nerve cells. That's not fully understood. I think it could instead be an immune effect. The virus does the more conventional model, gets down in the lungs or something, stirs up this inflammatory response, and then something about the inflammatory response takes out the thing. Or maybe it's even more subtle, as Derek puts in his question, that maybe it's hitting somewhere back in the wiring where this is getting converted to some sensation of a sense of smell. Seems to be probably a direct effect. I think they found ACE2 receptors on the nerve cells that are out in here. I'll try and check on that, and I'll try and make a note. I don't want to give. There's plenty of misinformation out there. I don't want to add to it.
Eloy shared a link to this article from CNN, and he wants to know if you can provide any insight or context into the recent Spain antibody study.
Yeah, I'll take a stab at that, because I glanced at that one. That's a pretty current thing. I think if we scroll down, who's sharing the screen, or who gave us
I
that?
am.
Oh, okay.
Let me know
I
how
think if we could, yeah. Oh, beautiful. Yeah, keep scrolling. That's okay. I did remember correctly. I think they said 5 to 16, somewhere around there, 5%. So, okay, scroll back up a little bit. I thought they may have. Okay. So here, as far as I know, and I didn't actually read the article, but I skimmed it for a minute. So they did large-scale antibody. Large-scale looks like they did almost 3,000 people. Oh no, that's the Geneva one. They took 60,000 people and looked at their serology, and they're finding 5% antibodies. See, if you don't develop antibodies, you're not immune. So that means that we can run this through the population, take all the losses, which, depending on who you believe, let's say it's maybe just 1% fatality. But let's say it's 10% of the cases get the long COVID. I mean, you know, I don't know how many people were on with Blanca, but Raquel presented us a pretty, she's not a happy person right now. I would not want to take a roll of the dice of being the up to 15% and more susceptible, 15 to 20% susceptible people, and then take your 1 in 10. So now you're down to 2%, but you got 2% chance of what's probably lifelong disability. If I offered a surgery to people for, say, cosmetic surgery procedure, and I said, well, don't worry, there's only a 2% chance of lifetime disability, I'd probably get run out of town with a pitchfork, because it just isn't worth it. And so this herd immunity idea that we're going to get immunity by developing the antibodies, by letting the thing run its course. And of course, that also means writing off grandma and grandpa or anyone in a nursing home, because their mortality then gets pretty high, up to 40% potentially. So that's pretty ethically horrible. Or the one-day-old in Louisiana that came down with COVID and got to experience a day of life, and that was it. If anyone happened to see that report, a one-day-old infant died from COVID. In Louisiana, that's their youngest case. So, and all you're going to get is 5% people even develop antibodies. And then how many of those people are really going to be immune? We're not sure. But if they don't have antibodies, they're not going to be immune. So all those people that you're sacrificing, like the experiment in Sweden, to achieve herd immunity, you're sacrificing for nothing.
So I was surprised to see the estimate as only being 5% because of just how horribly it hit Spain. Do these kinds of studies, is it possible that they somehow don't detect certain cases, or could they even overestimate?
You'd really have to do a deep dive. The short answer is yes in both cases. You'd have to do a deep dive into exactly what testing technology they were using. And now typically we talk about sensitivity and specificity compared to a gold standard. Ironically, there is no gold standard here. There's no real reference test that you can say, oh, if we go to this expense and trouble, we can really say, here's an exact answer, and then compare that. The AI people or the computer people will talk about ground truth. Very hard to get at ground truth here. You know, when things like RT-PCR, which is a pretty good, you know, relatively speaking for what we got, and that's got 20% to 40% false negative rate. So how do you get to a gold standard? Very tricky. You'd really have to dive into that CNN article to figure out which way the artifacts are. Is it biased up? Is it biased down? There's rates of positivity in California, Arizona, and I think 1 or 2 other locations that are running closer to 20%. And I don't know why there's a disparity between those numbers and what you're seeing in that article for Spain.
Lindsay asks, if you receive plasma as a treatment option, will you maintain antibodies yourself after recovery?
Best my knowledge, there's still plenty of investigational studies of the recovery plasma. The filtered plasma taken from recovering COVID victims in an attempt to transfer immunity. It's possible. I don't think we know the answer. There is downregulation. When you introduce those antibodies over time, they may get downregulated by other antibodies, believe it or not. Short answer, I don't think we know. And a lot of folks, there's going to be a lot of academic careers and a lot of papers generated by trying to answer those questions.
What do you mean by downregulating?
So one of my favorite topics, but it gets laughed at by real immunologists. It was a thing for a time, something called anti-idiotype networks. And that is the immune and clotting cascades are both actually network phenomenon with upregulation, downregulation, and very complicated amplifying and cascade effects that both upregulate and downregulate. So you get a stimulus into the immune system, a bug or something. The bug gets recognized. The body wraps up a response to it. Then the body recognizes the response and ramps up a response against the response. Then the body recognizes the response against the response against the response, and so forth, and creates the effect of a damped oscillation if you view it as one-dimensional. But it's actually a multi-dimensional network thing. And to make it more fun for systems people, it's actually an interaction between the clotting cascade and the immune cascade. Did that clarify, clear as mud for upregulation and downregulation?
Just a bunch of more questions, Gary.
Okay.
I do have a separate question, though. Thank you for that. And that's having to do with the brain. There's this this one disease, I think it was like acute, yeah, let me see if I can find it. It's called ADEM, I think, or ADEM, A-D-E-M. And they've had a lot more patients for this. It is called acute disseminated encephalomyelitis.
Yeah, so the question whether that's associated with COVID.
Well,
yeah.
They're saying it is, but you know, what are the long-term implications of this?
Possibly some brain damage, and I think he posted it in the what just got archived. I think I transferred the link over into that com-long-COVID. Sam Bernard put something about the neurologic, and I think that one touched briefly on that. Now, some of the neurologists are saying, no, it's different than the ADM. I forgot exactly the acronym or what it stands for, but I did come across that, some sort of myelitis. But they are speculating whether it occurs at least in some COVID, whether it's directly from COVID or whether it's related to some of the treatments that are used to fight severe COVID. and then whether it has long-term implications. If it does, it may actually produce long-term subtle brain damage.
Is there something people can do? You know, okay, you get COVID, you may have had a mild case, and you think, okay, I'll be fine, right? That's probably the presumption many have. Are there certain tests that people could take in order to kind of get like a diagnostic on checking these different areas to make sure they're okay?
We don't really have a great gold standard test. It's too bad Dr. Taleb isn't on the call. Ask him about IQ testing. That would be interesting. Anyone close enough follower for Dr. Taleb to hear him? He's not a big fan, I think, of IQ. There is what's called neuropsych testing. There's all kinds of, you can test for subtle cognitive deficits. And some of that testing is solid, and depending on what the deficit is, it can pick up some pretty good things. But some of that stuff, even our classical, we call a mini mental status exam, where you have somebody like draw the hands of a clock, or you show them a clock and then ask them to reproduce it 5 minutes later. I've run that test, on a couple thousand people in certain settings. And I've had it diagnosed dementia in some people who I happen to know were running cities and continued to do so for 2 or 3 years after. And I'm not sure what that says about municipal government or the test, but somewhere there's a problem somewhere in one of those two. It's so context dependent, depends on the patient. All right, what can you do? You know, when we hear a story like Raquel, it would have been more clear if she had had testing and if it was positive. But otherwise, her story fits reasonably. It could fit 5 other explanations, but by Occam's razor, it's not too bad for COVID and post-COVID. And her thinking is affected. Is there much she can do about it right now? Basic sleep hygiene, good nutrition, and then trying to work, as we all are, as best we can with our new normals. I hate to say that. You know, she's got a bigger burden in adapting to her new normal. I can't visit my folks without guilt right now, because, you know, that's part of our all new normal. I don't want to be the one that brings COVID to them. She's got a different new normal, and that's about where we're at, I think, for a lot of these subtle deficits, unfortunately.
So I ran some quick math on Spain population numbers. So 5% of Spain has antibodies, which is 2.3 million people out of 46 million people. From the math that I've seen, you need between 65 and 95% of a population to have antibodies in order to eradicate a disease with herd immunity, depending on the R0 that we're using for this disease. So at minimum, we are 10% of the way, best case scenario, we're 10% of the way to herd immunity, and they have had 30,000 people die. When you look at their death rate, if everybody who gets infected gets antibodies, then their death rate is 1.2%. If you look at their testing for PCR, they had 300,000 PCR tests that were positive, and they had 2.3 million antibody scaled to the population. I don't have the ratio for that, but that means that PCR caught 0.6% of their infection. No, 13%. So PCR caught 13% of infections. And PCR caught, no, never mind. Yeah, I did some bad math there, but 13% of population or of infections were caught by PCR compared with the antibody total, and the death rate was 1%, 1.2%. So
were they only using antibodies on symptomatic people? I'm puzzled when and how they use the antibodies and how they combine that with PCR data.
It may have been more like hospitalizations, because as Raquel told us, she didn't get tested because she wasn't serious enough.
Now, that was in her locality. We don't know if that applied across all 60,000 of those people, or do we?
True, but I think it's, if we're making assumptions, the safe one is that the PCR tests were mostly given to symptomatic people.
No, but I'm also puzzled by their mixing antigen tests. I don't know that I'd make any assumptions. I'd be very hesitant about drawing any conclusions based on
True.
this.
I just ran some quick math to kind of demonstrate a bit of the situation that we might be able to assume. But this is really still sketchy data. We've never really had good data for COVID.
I started looking just very quickly at the methodology for that study that is in the CNN article, and it begins by saying that 35,000 households were selected from municipal rolls using two-stage random sampling, all residents invited to participate. So it doesn't seem as though they were isolating just people who had had COVID symptoms. They were sampling just a broader selection of their population. So that might be something to look a little bit more at, and maybe we could think more about the limitations of that study based on their methods. Oh, sorry.
Is the, just to follow up on that, is there a request, hey, we're gonna make this study that's about antibodies? Or the request just like, hey, we're gonna do this random study? Because I think whoever you get in is going to skew the data as well, right? Based on what the request is.
Yeah, to try and scale a random, like a trial, like the polling, it's a nightmare to try and generalize from those data sets. The generalization here, matches a number of others. So, if we're trying to work out like a death rate number, one something seems to be relatively consistent. But this is really, really difficult to do reliably and confidently. I'm like 1 and over, like 1 and greater would be my kind of thinking for COVID death rate. But let's go more on long COVID. Do we have any understanding of the foot and knee inflammation that Raquel was talking about? And also kind of the asymmetry in her inflammation.
That could be an immune thing. I mean, or anything, or reduced mobility, or an anxiety thing. It's or even a sodium of 111 is actually pretty low, and that can cause all kinds of symptoms. So something's going on there. Maybe it's just testing artifact. I don't know the quality of the testing lab, but because I didn't hear anybody raising the flag. She was there talking to us instead of sitting in an ER getting evaluated or treated for her low sodium. So that was a puzzle I had in the back of my mind, but it didn't seem like it was a mystery we were going to be solving on the call. And I'm a little while out of clinical practice. It's been a while since I really would have been the one managing that sodium. But a sodium of 111, that's not usually a new finding of a sodium of 111, as I recall, would not usually be an outpatient thing. You'd be managing that with an ER workup if you didn't have a good reason for it. And that could cause all kinds of oddities, including some headache or some seizure.
And some exhaustion too.
Yeah, oh, definitely. So, but you could have an immune thing flaring up, and like arthritis, gout, if you think of, if anyone knows any in their family with gout, it often will hit one joint, on one side. Those are all immune kind of things. A lot of times your arthritis hits one side worse than another. I wasn't sure what to do with that part of it, but broadly somewhere in the area of immune or neurologically mediated problem, and or some weird effect of the of the sodium. Another possibility in her, it's a less likelihood, but it's not impossible, is parathyroid. Turns out folks with parathyroid disease, it will travel sometimes with thyroid problems. It can produce some subtle psychological disturbances, and it can produce some chronic pain, and it can produce some migratory stuff, pain that moves in different places over the body.
Can you tell us about uric acid that causes gout?
Gout is from urate crystals, yes. Problems with uric acid metabolism, gout.
So is there anything we have to avoid as food?
You take that allopurinol, and isn't it the food that's rich in purine derivatives or something that you try and minimize? You cut down on certain proteins, and you got to keep alcohol out of the picture. I forgot exactly the connection between alcohol and gout, but they do. Yeah, you can modify your gout attacks by keeping purine. I think you're not supposed to eat peanuts or something with purines in it, if I remember. It's been a long time since I dealt with that one.
Okay, thank you.
Don't eat like a king every day.
That was in medieval times, podagra. That was an affliction of the wealthy. They were the only ones who were able to eat enough to get it.
Yeah, my father always says eat like a poor people, you know. 70% of India lives on like what? Rice and beans. So don't eat even if you get it. And he was educated in France, so portion size.
And he had longevity, right?
Yeah, he had diabetes at age 33 and he passed away at 93. So 60 years with diabetes, no complication.
So his medical advice you could rely on. Someone who passes away at 35, not so much.
Mm-hmm.
Lindsay is asking if antibody tests are accurate. She says, I've heard mixed reviews, but could that significantly affect the data or not by much?
Yeah, that's our friends at adveritas.dx. Tracy Fausterman, Tony Morrison, and Aaron Gleiberman are all active both in, mostly with adveritas.dx, a little bit in coronavirus, and a little bit in National Scientist Volunteer Database. Adveritas.dx maintains a website with a database of different antigen tests and manufacturers and where they're at in the with the U.S. EUA's emergency use authorization process, and their positive and negative predictive values. That's when I said we'd have to really do a deep dive into the Spanish paper. You'd probably have to start to figure out which antibody tests they were using. Okay, and Gio says the testing is pretty shoddy and untrustworthy. It's a problem right now getting to ground truth in COVID. I don't know if, I guess it is fair to say shoddy and untrustworthy. There's a lot of noise in a lot of the tests. And
kind of, I've been looking at the data sets since February, and I've pretty consistently gotten 2% as the most reasonable conservative estimate, and that's with standard of care, so modern medicine, good hospitalization, available resources, all that. If we aren't able to provide treatment, the death rate could go up to 8% or higher from my estimates. And some of the third world places, I believe it is Guayaquil in Ecuador especially stands out as an example of what happens if you don't have good medical and infrastructure, as they had bodies in the streets because they couldn't even bury people fast enough. And that's kind of what happens with this disease when it strikes, spreads, and there's no way to manage it or treat it. It's really a terrifying thing. This is not a trivial disease. So that's a bit of what we can, best guess is, in that range.
well, and of course the problem is places that don't have good testing places that don't have good healthcare are going to have high death rates, and they're going to have poor public health infrastructure for measuring those death rates. So, presumably certain parts of the world are seeing plenty of COVID deaths that are going to be unmeasured because they don't have good, they don't have ways of accurately tracking their causes of death of all causes, let alone COVID.
Yeah.
Gary, would you like me to share screen with that link you just shared?
Oh, sure. If you think it's helpful to the group, sure.
Yeah, if there's anything you want to tell us about it, we'd love to hear.
Okay, yeah, we could try that screen sharing. They're good people. I mean, I know all of them. I know those three personally, and they're wonderful, very sharp people. So yeah, I haven't been on this lately, but so this gives you an idea how many. And I think over to the right, there's a filter. Okay, you see the little search icon? Go over to the right. Yeah, there. So you can look for some specific type of testing or a specific manufacturer.
Mm-hmm.
And I think then on the bottom, is there a bar where you can scroll horizontally? And yeah, no, keep going. You see the gray? Yeah, okay, you're doing it. And you can find its status. You can find some positive and negative predictive values. This is basically a spreadsheet. It's in Airtable. So it's a pretty interesting website, pretty comprehensive. You see that scroll bar, if you go down a little, you
No,
can
move your mouse to the bottom of your screen, slightly to the left, gray thing that's circular ovoid.
over a little to the
Other
left.
Yeah, okay.
Or give
See
one of the things up.
Airtable? Yeah, go
I'm over to the right now.
Right of Airtable by 3 Airtable widths. Yeah, there you go.
Yes, this is lots of great information in here.
Yeah, and I think somewhere there's columns with positive and negative predictive value too. And I think somewhere they also, one of those, and I think they actually say what they're defining those predictive values as.
Right, so great resource to look into further. And then I think there was one more thing in the chat around Tracy brought up sewage and wastewater testing. Do you have anything that you'd like to add or share about that?
Yeah, so some of the world experts in that are that kind of had some of its birth here in N coronavirus. That's Kevin Shallard helped nurture some of that. Marty Romeo, Cassidy Mentis is a mathematician that worked with them to do adaptive batch testing protocols, and it's the same groups that we're also looking at DPCR, digital droplet PCR, which is a high throughput appropriate for things like nursing homes, anywhere where you got to do a lot of high volume repeat testing. Military barracks, prisons, we're trying to get that on the ground in the right places. But the wastewater is good for community level surveillance. You measure what's called influent. The channel is poop testing, I think, elegantly named poop testing. And you monitor for RNA in the wastewater. You can get some idea, and Tracy, you may know more than I do, but you can get some idea of the level of prevalence in the community, a rough correlation, but you can know reasonably well whether or not you've got some COVID in the community. And it turns out it's an early signal because it starts showing up in at least some people in the poop early before they have a lot of infections or before they start dying. If you're just watching deaths, that's a late indicator. There's a lot of lag. But it'll show up in the fecal stream a lot sooner. So that lets you know, let's say you get to a green zone, but you still have 1 or 2 travelers, or say you have a porous border. So you think you got community transmission stopped, but then you can't control people coming in and out of like Costa Rica's in that situation. They really can't control their Nicaraguan border. And so then you monitor wastewater, and then that way you can know early whether you got to go to a lockdown and start getting aggressive with contact tracing and things like that, so that you can stomp it out again and get back to green zone and eradication quicker.
Gary, I have a quick question for you about your fellow doctors and nurses and stuff. Do you have many doctor or nurse or medical friends that sort of doubt that COVID is a big deal? We saw a lot of that, we saw some of that early on in COVID, where there was like groups of doctors that are just saying nonsense. Is it still widely held belief that it's no big deal?
It's really weird. And a kind of friend of mine / social media acquaintance I've never met, and he's sort of a rock star celebrity in certain circumstances. So calling him a friend is a little bit maybe overstating it. But he's involved in system safety, high performance diving, and aviation safety. And he just put out something on LinkedIn that I got to review. It's all about cognitive biases in healthcare leadership and in clinicians and in politicians, and how that's been, letting the virus have a heyday. And it came on my radar today, and I can't wait to dig into it. In aviation, they talk about human factors and cognitive biases. They've been doing that for years because it's an important cause of why planes fall out of the sky. But now it's an important cause of why we've got worldwide spikes, the denial and all that. All right, bottom line. So my friend Craig, who you may have interacted with a little on Facebook, he's actually an infectious disease specialist at Montefiore in the Bronx, and he saw plenty of COVID in the last few months. And he is just starting to now come around to some of the posts that are, he's sort of funny. Derek, do you know who I'm talking about? Does that have any recognition for you? Because I know you've been in and out of some of those posts. And he's saying, oh yeah, I guess we are hitting sort of a second wave. And Craig is no dummy. He went to Harvard, but we won't hold that against him. Okay. There's a few on this call who also share that heritage. Craig and I have known each other for years. For a while, he was dicing and slicing the statistics nationwide and saying, oh, most of it's New York and we're getting ahead of it anyway, so it's not such a big deal. And now he's sort of coming around to, oh, yeah, it looks like we're heading into second wave everywhere. And yeah, we're all sort of, we might as well we're all sort of toast. I think he used another term or something. But, and it's been an odd sort of shift. And, but he's been in the thick of it, dealing with the cases. A friend of mine's a respiratory tech here and also happens to be mayor. And he shook my hand and was not wearing a mask nor maintaining distancing in his little local wine bar. And that astonished me as he was telling me about the COVID cases that he had just finished taking care of here at the local hospital. So I don't see any more or less rationality in my medical friends than I do in the rest of my friends. And I see, it's just an odd mix, and we all got our biases, and it's an amazing thing. And the virus is just having a party every day, and just so happy that we have these odd quirks in our wiring. That's all I can figure. The virus, not us, being happy.
Gary, I wanted to ask you about blood clotting and amputation. This one guy, he's 41 years old. He ended up dying after I think 2 to 3 months being in the hospital. They ended up amputating his leg. I'm wondering if that has to do with blood clotting. You mentioned that it can go either way, right? Where it clots or it actually goes the opposite way. Can you speak more to that? Yeah.
Okay, and Eloy just posted, there was at least one celebrity, I think a Broadway celebrity, lost his leg. And then did he actually pass away also? I'm not sure.
Yeah, this weekend.
Yeah, there's been some pretty horrible things go on. So I actually did that literature search a little bit for Jonathan one day quickly, because Jonathan is on the call with us and helped connect us with Raquel and with Blanca. And there's not a lot out there yet about either the anticoagulative effects or the procoagulative effects, but isolated case reports like that one. And and then Tracy B asked about a comparison to the 1918 pandemic, which is an interesting topic. So short answer, we know it affects the coagulation system. And so this thing, watch, it's not just the lungs. Jeremy is absolutely my favorite virologist. He still likes to stress it is a respiratory illness. I'd like to put an asterisk after that. I think he's right, but I think it's a respiratory illness with an asterisk. It very clearly in some patients causes hypercoagulation. That 7 out of 12 DVTs in a developed country, that's in Hamburg, Germany. We're not talking in the Sudan. This is Hamburg, Germany. This is a Western industrialized G7 nation. And they're finding 7 out of 12 unsuspected deep vein thromboses. That's astonishing in 2020. If in 1993 or 1998, when I was a chief resident, if I had 7 out of 12 of my surgical cases with a deep vein thrombosis, I would still be in prison from the medical malpractice of allowing that to happen. And the hospital administrator would be in the next cell over for allowing the system to be that dysfunctional. So that says that there is some huge clotting problems going on with these. Did that contribute to that one actor's loss of his leg? It may well could have. I don't know the details. I don't know if he was a smoker or diabetic, if he had pre-existing vascular disease, or if he got all those problems from complications from his COVID. But I think the fact that it affects the coagulation process, and then in other patients, they've actually had to give sometimes they've had to give anticoagulants, and sometimes they have to give clotting factors, and it seems to depend on the patient.
wow.
But once you start messing with the clotting cascade, it's bad business, and once you
Well,
start messing with the circulation, it's bad business.
Early on, if they were perhaps being misdiagnosed, they could have given them medication that was exacerbating it.
Right, right. If you don't know what to look for, yeah, exactly.
Wow.
Yeah, you can create a vicious cycle, or you can think you're really helping, but if you're missing some other thing that's going on, then you might kill the patient accidentally while fixing. You'll win a battle and lose a war.
Are we doing anything about that? I don't know if you're familiar with MCRIT Crew, or if anyone else on here is. It was this group of doctors out of New York, some from Italy too, really focus on the intubation part, because about 80% of people intubated were dying, right? And so, some of their findings were that people were being intubated prematurely, and that, high nasal flow and, other type of respirators along with proning could actually be more effective towards recovery, and that the intubation might have had adverse effects, or intubation
Yes.
early on. But I don't know if we, ECV, are focused on any area like that. In order, like, they're doing good work, but is this being distributed well to other hospitals so that they're learning from these best practices?
I don't think we're in a position to do that. I think we got enough on our plate personally. I'm familiar with MCRIT, and I'm familiar with they called it prolonged non-invasive ventilation. I forgot they had some clever acronym. And there was that guide going around for a while. Early on, the Chinese, bless their hearts, the Chinese Centers for Disease Control, I occasionally wear a uniform. I can't tell you how much that sticks in my throat to give credit where credit was due. But they had a pretty good comprehensive summary of treatments early on out of Wuhan that was promoted by the Chinese Centers for Disease Control. And I mean, all I can say is respect for them for putting it out there. It was thorough, it was well translated, and as best anyone can tell, it holds up now. I think it was pretty good data, and it was pretty humanitarian of them to share it with the world. Eastern Virginia Medical School, Tabes Medical School, put out a good guide. Wasn't as comprehensive as the Chinese one, but it incorporated a lot of the MCRIT stuff. I think the clinician networks, as faulty as they are, I think they're going to work better than us trying to enhance those networks. I think we're better. I think there's other audiences that we can reach more effectively than that one is my best guess. Having still participated a little bit in that message trafficking. I'll switch gears for a second and then I'll mute, or I'll mute for a moment. Did that answer that, Joaquin?
Yeah, it did. Thank you so much.
Okay. Here's something. This is from this Not Just the Lungs, and this touches on that 1918 comparison that Tracy mentioned. So yeah, I think we understand much better what the flu does. We have much more experience with the flu. And is COVID especially contagious? So yeah, we've got flu vaccine. That's an Eloy question. We've got vaccines that are not perfect against the flu, but they two things with the flu. One, we have a vaccine that gives us some immunity, and we've got a whole infrastructure and system for trying to guess each seasonal flu and at least try and stay ahead of it. And then also we've got some degree of immunity for some of the flu viruses. So the flu takes a lot of people, and it seems to be pretty contagious. Would it be much worse if there wasn't a vaccine? Yeah. And would it be much, much worse if flu was new to us since late last year? Then we'd be back in 1918 kind of numbers, because one of the things that probably helps us is having some degree of immunity. Okay, and is the comparison that the politicians like to make early on, and that unfortunately I still see creep up in articles where they start comparing the death rates from flu to the death rates from COVID. That gets back to Tracy's question. It's just the flu. Yeah, I think that's a big mistake. I think we have much more experience with the flu, and it probably doesn't seem like there's a post-flu syndrome or long flu. You know, we've got some things that we don't fully understand, chronic fatigue syndrome, stuff like that. I don't think anyone's going to suddenly have a light bulb go off and say, oh, turns out chronic fatigue syndrome was post-flu. If that really were the cause, that would have shown up epidemiologically years ago. We have much more understanding of what to expect from flu than we do with a big unknown like this virus that's pretty new in the community. And that's one reason why I think COVID needs to be taken much more seriously. If that makes sense, and if that answers, Tracy, does that answer your question about comparisons to the flu?
Yeah. Also, there was Peter Attia's recent COVID specific podcast. He interviewed someone, and he compared the COVID to be something like a mix between a common respiratory illness plus severe SARS-CoV-1. And so it's the upper respiratory part where it's very infectious, but it's not so deadly. And it's the lower respiratory where it's very deadly. And if you were to, because you have the numbers baked in with the upper respiratory and lower respiratory, it seems that it's not such a deadly illness. But if you were to compare it on the deadliness of the lower respiratory infection, it's as deadly as SARS-CoV-1 and MERS. And
the thing is we don't ignore the flu. We've got infrastructure, we've got systems for trying to control it. And so, yeah, I mean, if you're in a nursing home, then this is at least as deadly as SARS or MERS, right? For the vulnerable populations.
More deadly. I mean, compared with SARS to the whole population, that was about like 8 to 10%, and this disease is 15 to 25% in such a.
It's an interesting split to compare like the milder ones to that would be the upper respiratory version of it, and then the more severe ones is the lower respiratory, if I'm understanding that framing.
Yeah, so the upper respiratory, basically, you don't get the cytokine storm. You experience a very mild version of the virus. And because it's upper respiratory, it's also very easy. It's a lot easier to spread. So with SARS-CoV-1, it was much more difficult to spread because it was lower respiratory, and it only really spread in hospitals when they did the intubation. But now SARS-CoV-2 is like a combination of the two. So it's very easy to spread. And in the mild version, it's kind of mild, and it's upper respiratory, it's mild, but then
because there's few illnesses that have the killing potential where there's a large number of people still walking around with those illnesses free in the population. You send your kids to school, they get the upper respiratory mild version, let's hope, and then they come home and give grandma and grandpa the killing version. And they don't even know it. You know, if someone's got rabies, you know, it gets figured out quick, and they're not spending a lot of time infecting the rest of the population. If someone has a common cold, they might give it to a whole bunch of other people in the population, but it's not usually as lethal, even to the older or the more vulnerable. This one, someone's walking around with that mild upper respiratory, but then they give it to someone who's susceptible, and now that person has 15 to 20% mortality. You know, that's a problem. I'm going to, looping back for a minute here, this is from this Not Just the Lungs one. They're talking about the effects on the heart, but they mentioned the vascular endothelium. Endothelium is the lining of the blood vessels. Forget the clotting stuff that we talked about. Here it just says, heart failure, pulmonary embolus, that's a blood clot that comes from the legs or somewhere. Oh, Peter Attia podcast, okay. That's that with the high mortality for the lower respiratory. And the problem is we got people with the upper respiratory version who can give people the high mortality of the lower respiratory, and they're not in ICUs being isolated. They're out and about in the population. So, all right, back to the heart and the blood vessel lining. When these pulmonary embolus, that's a clot going to the lung and shutting off the circulation might reflect the fact that ACE2 receptors are highly expressed in cells inside the walls of capillaries, in the walls of blood vessels. When these vascular endothelial, the blood vessel lining cells, become infected, the resultant damage can cause clots. This is someone from MGH up in Boston, Mass General Hospital, which in turn can cause COVID toe, strokes, and also ischemic bowel. That I've taken care of ischemic bowel before. It's a horrible condition. That's when the circulation got shut off to the intestines, too little blood flow in the gut. Studies from around the world suggest that 7 to 31% of COVID-19 experience some sort of cardiac injury. And so they're speculating that that could be, they don't emphasize the clotting part, but they do emphasize the circulation problem. Okay, Gio is saying it's time to go to bed. I'm shutting up or muting.
Well, it's not time to go to bed, but I just wanted us to keep track of time and not get lost on that. So if we want to focus on some more questions, that's fine. But if we're all kind of good with the 2 hours of discussion on long COVID, then we can call it a night. It's up to us.
I just wanted to add one more podcast recommendation from Peter Attia a while back. He interviewed someone, and their theory was that coronavirus is an infection of the epithelial cells, and that's why it kind of gets into the blood. And I'll find that podcast and share the link. But it was also an interesting. It was an interesting theory.
So the epithelial cells, or was it epithelial or endothelial?
I think it was endothelial. And when they looked at the cells, they were full of this virus. I think that was the take home. And
that darn ACE2 receptor is so ubiquitous. It's everywhere. And then also all you have to do is cause some little microemboli, little microscopic blood clots, and those also will damage the endothelium. If there's a blood clot in the leg, for example, the blood vessel linings of that leg will never be the same even after that blood clot is gone. And from then on, that person will always have a propensity to forming new blood clots in the leg, even if their clotting system is completely normal. So it could be through either effect, and it's very hard to tell in a given patient which.
Gary, I don't want to prolong things, but I have another question. So there's this treatment where if people can't get enough oxygen in through their lungs, you can take out their blood, put the oxygen in the blood, and put the blood back in. Can you explain how that's done?
Yes, extracorporeal membranous oxygenation. It's not easy. It's very resource intensive. It requires highly specialized teams. And Joaquin gave the accurate, brief, clear summary of the entire 2 hours in the chat. Don't get COVID. Yeah, thanks. Thanks, Joaquin. I think even I can understand that one. Okay, ECMO, I'm pretty sure we're talking about the same thing, and it's being used with some success. It's almost like putting a person on bypass for cardiac surgery. In the time where I've done it, you cannulate the vessels. You gain access to the circulation here in the neck. It's a little bit tricky. We used to do it on infants. I'll spare everyone those stories. It's not all that easy in adults. It's really something to do with the little vessels for infants, but it is doable, especially if you do it a lot. You take the venous outflow, the stuff that's and the arterial inflow, the stuff that's coming oxygenated, or in this case not oxygenated, because the lungs are you're temporarily replacing the function of the lungs. But the stuff that's already had its journey through the lungs and now is getting ready to get sent around the body, you grab it, intercept it, put it through a mechanical oxygenator, a membrane. That's the ECMO, extracorporeal, out of the body, extracorporeal, membranous oxygenation. It's an artificial lung. You oxygenate the blood, and you may augment the pumping or not. In cardiac bypass, we call it putting a person on pump. I honestly don't remember with the ECMO machines. I think it mechanically also augments the circulatory. Not only is it oxygenating it, but it's adding some blood pressure. It's pushing it, it's pumping it along in the flow, in the mechanical circuit. And then you put it back in the circulation and let it go deliver that oxygen to the cells. And when it comes back unoxygenated, it's been probably 25 years or 30 years since I would have done ECMO, and it would have been on an infant. But we were probably also taking the carbon dioxide out. I've participated in both those procedures, putting people on and off pump for bypass and the ECMO. The one's done with an open chest and you cannulate the aorta. The other's done here and you access, as I remember, we did jugular for the venous outflow. And I think we took the inflow from the innominate from the circulation as it comes up in the aortic arch there. They may have some newer, that was a long time ago. But basically you're interrupting the circulatory loop, you're grabbing it, you're probably adding a little mechanical power to it, but you're taking out the carbon dioxide and putting some oxygen in and then giving it back to the person. Did that answer it?
How do you connect a human tube to a rubber tube?
Oh, back in the day, I'm sure they got better ways, but we would do basically a variation of a procedure called a cut down. Got a blood vessel. This shiny thing is standing in as a nice red plump round vein or artery. You make a cut like this. Depending on the circumstances, you might temporarily put a clamp. Maybe it's a cushioned clamp so it doesn't damage it much, or you put little elastic string loops around it. You do something so you can constrict the vessel temporarily. And depending on the vessel, you might do that upstream and downstream. You make a cut across here. You slip in what's called a cannula, like an IV, and you loosen up your tie or whatever gently, momentarily, so you can slip that tube across. Then you snug it back so that the vessel is now snug around the outside of that tube. And then you let her rip. And you do a bunch of stuff to make sure you don't get air bubbles in the whole process. And now you've got access. I've done that, variations of that procedure, probably in most of the vessels of the body one way or another. Did that answer that? Okay.
That was amazing, by the way, Gary. You're just amazing. Thank you for sharing all your knowledge with us. Amazing.
No. What's amazing is 2 hours later where you go hide in the restroom and then you just crumple and you're like thanking your lucky stars that, the 1 or 2 times that the patient made it off the table. But you don't let anyone see that. You walk out of the upper room, well, just another case. Let's go get coffee. Yeah.